First question today is from Karen, and Karen asks, can you give me a primer on ACOs? As our practice joins an ACO next year, what issues do you think we should consider?
Oh, good question, Karen. There's issues, I mean, important issues both at the ACO level and issues at your practice level. And it's basically looking at the same set of issues at each level. One, how credible is it that there will be savings to share? Is there data to show where your problem areas are, where the most likely areas are going to be that you can generate savings? Lacking data, is there solid logic or theoretical data that guide action that you can pretty much count on resulting in savings? And if the ACO is going to generate savings, will your practice have an achievable role in generating those savings? And as the ACO generates savings, how will those savings be distributed to the participants? Will you, as a practice, be able to benefit, and will you benefit proportionate you feel to your contribution to those savings? And finally, what support is the ACO offering that will help you make the changes in your practice that will contribute to the savings? As you look at the credibility that you'll generate savings, there are a few things that just make sense. First, is there easy access to primary care services in your area? Are you overpopulated, which I don't know any community that is, or underpopulated in primary care providers? Uh, is it credible that you can encourage your patients to begin their healthcare episodes in primary care? There's some good evidence that those episodes of care that begin in primary care end up costing about half those that either begin in the emergency room or are self referred to a specialty rather than starting in the primary care office. Another thing that simply makes sense is excessive access to expensive options. Uh, tends to generate those expensive options. If there's open appointment slots in your MRI scanning unit, you tend to generate more MRI scans when lesser cost imaging will do just as well for the episode. Excess capacity in a cath lab and or excess a supply of invasive cardiologists in your area can lead to higher than needed procedures, and every specialty has their examples of this. Dartmouth's microsystem design teams define indicated care, supply sensitive care, and preference sensitive care, and we often find unwarranted variation in that care that is supply sensitive. Uh, or preference sensitive. And I think usually the dynamic with that is preference sensitive care is something that can become supply sensitive. That is, we as physicians have potentially excessive influence in helping a patient decide which option they should take. And we tend to guide them to things where we have excess capacity, where we make more money. There's some very powerful, if subtle, dynamics in the healthcare system that lead to overindulgence when that is available. Planned care in general is better than the chaotic care. If you're reinventing the wheel every time you see a patient and see this problem again, it tends to be more chaotic. We ought to categorize the common episodes of care as they present in our region, and understand how each of those categories move through the local healthcare system. Look for opportunities to each episode of care more efficient, speed recovery, eliminate duplication of efforts, and eliminate errors, eliminate complications. In general, take unnecessary waits and delays out of the equation. if you have data, and I hope you will, and if you don't, look at our options. Be delighted to be helpful to you. It's not a simple matter of looking for the highest expenses. It's a matter of looking for the expensive care with a preferable option that's less expensive. Uh, and a clue to that is looking either in your system or at neighboring systems or nationwide to see where the most variation exists. Variation usually indicates that there's opportunities to reduce uh, the cost of care by making different choices, by guiding patients in different ways, giving them the well-informed patient typically makes the well-informed patients makes the decision that's best for them. And as we can get to that, we often find that we've exerted unnecessary or unwarranted guidance to the patient and led them to to an overly expensive choice. So good luck. It's a moving target, unfortunately. Medicare rules today to establish the shared savings may not be the same as they are tomorrow. Many organizations have found that as they generate savings, the goals ratchet down, and it gets harder to generate savings in future years. Medicare is listening to that. They're changing. You can expect these rules to evolve. But at some point, you'll want to leap in, and when you can credibly perform well and help guide the system to a better future.